In our third session, we'll see that by 2000, there was widespread agreement that managed care had failed, but managed care advocates didn't stop promoting the managed care diagnosis and the overuse due to fee-for-service and the managed care solutions. They just invented a new name for overuse, low-value services, a new name for HMO, ACO, and a new name for managed care, value-based payment, and pretended they were selling something new. But first, we take a closer look at how managed care ideology turned Minnesota into a high-cost state. And that's what we're going to do in this session, session 2. This session will address the question, how did Minnesota become a high-cost state? And we're going to see that the Twin Cities and the Bay Area out in California led the nation down the HMO managed care path. And these pathologies that managed care set loose struck Minnesota first. And so we began to see mergers here first. We began to see administrative costs soar first here. And we'll talk about the spread of managed care, how it drove up administrative costs and provoked enormous, unprecedented mergers in Minnesota. And we'll look at some of the evidence indicating high prices, not excessive quantities, is the reason Minnesota healthcare expenditures are high. This is the slide which we want to explain. You've already seen it. Something happened in the early 90s, and by 2000, we were spending 10 to 12% above the national average. Compared to we're spending 10 to 12% above the national average. This slide confirms the previous slide. You see that Minnesota costs, this is a report from the Star Tribune, 1996, reporting that by 96, Minnesota employers in the Twin Cities were paying almost 12% above what employers across the country were paying in healthcare premiums. And for the average Minnesota employer, they were spending 7% above the national average. I have included this opening sentence from a Wall Street Journal article about the so-called healthcare reform in Minnesota. Notice that it's just dripping with irony. Dateline Minneapolis, here in the cradle of the managed care revolution, the dragon of inflation is reviving with a vengeance. That wasn't supposed to happen. We were supposed to be leading the nation in reducing costs by relying on HMOs. Now, in this slide, I want to walk you through the chain of events that led to the explosion in Minnesota healthcare costs in the 1990s. We began again in 1970. That's when Dr. Paul Elwood, the Minnesota doc, invented his little manipulative label, Health Maintenance Organization. And he sold the concept not only to the Nixon administration and Democrats in Congress, but he went around Minneapolis and St. Paul selling it to Fortune 500 companies. In 1973, Elwood and some Fortune 500 companies persuaded the Minnesota Legislature to enact an HMO Act, which basically said, if you qualify as an HMO, you get to practice medicine. You will not be violating the prohibition on the corporate practice of medicine. Between the encouragement of the legislature and these companies, by 1990, half of the metro area in Minnesota was enrolled in HMOs. In the 70s and 80s, HMOs used their growing market power to extract large discounts from docs and hospitals. Hospitals responded by merging. By 1990, insurer and hospital markets are tightly consolidated. In other words, the few remaining players are all set to pass on any new administrative costs this crazy system imposes upon them. In 1982, on advice from Elwood, the Al Quie administration begins the process of privatizing Minnesota's Medicaid program, known as medical assistance. And that entire process was completed in 1996 when our legislature, drunk on managed care Kool-Aid, authorized the complete privatization of medical assistance and Minnesota Care. But here in these years, 1991 to 93, is when stuff hits the fan. Two commissions, one reporting in 91, another in 93, and the Minnesota Legislature endorsed HMOs and managed care as the solution the entire state should adopt to reduce rising healthcare costs. The Minnesota legislation and the second of the two commissions did not use the word HMO. They used the phrase integrated service networks, a handy euphemism that means HMOs. So given this rapid fire endorsement of HMOs as the solution to the healthcare crisis, all the players now in the Minnesota system recognize that large size is a priority. And at this point, historically large mergers broke out all over Minnesota. This slide contains an excerpt from an article written by the Minnesota Historical Society. It accurately attributes the invention of the HMO to Dr. Elwood, and it describes a pilot test of his HMO concept conducted at the Park Nicollet Clinic in St. Louis Park, using 5,000 employees of General Mills, Dayton Company, and some other Fortune 500 corporations. We also learned from this excerpt that Elwood promoted HMOs to the Nixon administration in order to head off Medicare for all. You can see here, they say that Dr. Elwood and his associate, to them, passage of Medicare legislation in '65 seemed to portend a slide towards socialized medicine. Far better to have HMOs than Medicare for all. You see here that HMO enrollment in the Twin Cities grew rapidly during the 70s and 80s. And as HMOs grew, hospitals reacted by merging. 4 hospital chains dominated the Twin Cities by 1990. This is data from a paper published in Health Affairs in 1991 describing the takeover of urban markets by HMOs. And you see that by 1989, only the Bay Area had more of its people enrolled in HMOs than Minneapolis, St. Paul. There were some other urban areas not far behind, but we were way ahead of the pack because we're so smart. Now, you recall a slide in the last session in which 2 Health Partners executives stated that HMOs use their market power to extract enormous discounts from hospitals in the Twin Cities. Now, in this slide, you see another HMO executive saying the same thing. The executive in question is George Morrow. He was the CEO of this HMO, Physicians Health Plan, for only 7 months. This plan is long gone, got merged in with some other HMOs. And after 7 months, he had seen enough. It's kind of like Wendell Potter. From the inside, he didn't like what he saw. And he said to CityBusiness in 1988, managed care is a shell game. It's a game no one can win without causing others to lose. In Minnesota, we built a managed care industry on the backs of the hospitals. I would say that's one exasperated dude about something he believed at one time. Now, you might think that by the early 1990s, the legislature would have grown concerned about the behavior of the HMOs and the role they played in the consolidation of the healthcare system. Be wrong. Egged down by 2 commissions, the legislature passed a bill in 1993 that provoked even more mergers and encouraged the spread of managed care tactics into rural Minnesota. The first of the 2 commissions to recommend more managed care, more HMOs, more PPOs, was this commission, the Minnesota Healthcare Access Commission, which met from 1989 to 91. They issued their final report early in 1991. And here's what they said. We recommend that Minnesota control healthcare costs through managed care organizations such as HMOs and PPOs. Use of these plans will lower costs for the state. And I can't say in loud enough terms, there was not a shred of evidence offered for this statement. And I attended all of the meetings back then of that commission, and nobody introduced evidence documenting that statement. The second commission made the same recommendation early in 1993, only they invented the euphemism integrated service network for HMO. This is a common problem with managed care folks. They're constantly inventing new terminology that doesn't tell you what the thing is supposed to do. Then in the spring of 1993, following the recommendation of the two commissions, the legislature hauled off and passed HMO legislation, calling it an ISN. Here's a report in the spring of 1993 from the Star Tribune. The chief author in the House, Representative Lee Greenfield, says, now we've made a very strong commitment to use managed competition as a technique for keeping costs down. Managed competition is just the expectation that HMOs will somehow compete with one another and they will reduce costs and improve quality. The mere discussion of endorsing HMOs and integrated service networks prior to 1993 set off merger mania, and the 1993 law just threw gasoline on that fire. And here's the op-ed in the Pioneer Press from Bryan Dowd, who I think he's still at the university, he's an economist. What he wrote was, preceding and concurrent with the discussion surrounding the ISN legislation is an unprecedented level of consolidation in the health plan and healthcare services market in Twin Cities. He went on to say this does not bode well for containing costs in Minnesota. Surprise, surprise. This study shows you, this is data I prepared for a document Minnesota COAC released in '95. We showed that the big four insurance companies increased their market share from 64% in 1992 to 80% by 1994. And it got worse by the year 2002. You see here data from Health Affairs, published in 2004, showing Minnesota amongst the 6 states with the most highly consolidated insurance markets. Now you see that the largest 3 insurers enroll 89% of all customers. Single largest insurer, in this case Blue Cross, controlled 53%. Now I turn to the last of the major events that caused Minnesota's healthcare costs to explode in the early 1990s, the privatization of medical assistance, and later, in 1996, Minnesota Care. As I noted earlier, the process was started by Dr. Paul Elwood, the so-called father of the HMO. In 1981, he wrote a letter to the Quay administration urging DHS's predecessor, the Department of Public Welfare, to apply to the predecessor of CMS, Healthcare Financing Administration, for permission to turn medical assistance recipients over to the tender mercies of HMOs. The Healthcare Financing Administration gave Minnesota permission to test HMOs in just 3 counties, Hennepin, Dakota, and Itasca, and on the condition that the Department of Public Welfare conduct a rigorous evaluation of the HMO's performance compared with non-HMO fee-for-service doctors in adjacent counties. So the original plan was that the Department of Public Welfare would collect data from the HMOs and then compare, let's say, their performance in Hennepin with the performance of the non-HMO docs in a next door county. I think it was Ramsey. It never happened. HMOs refused to cooperate. DHS staff tried to evaluate the HMOs one last time in 1993 using the incomplete data they had, but DHS's commissioner suppressed the study under pressure from the HMOs. We know this only because someone leaked the study to the HMOs. This is a headline from the front page. That date, say, March 13, 1994. Here you see some excerpts from it. Minnesota officials suppressed the study, raising questions about HMO care for poor people. And so the opportunity to evaluate whether HMOs were all they were cracked up to be just went by the wayside. And both Congress and the Minnesota Legislature said, never mind, we want to continue to privatize Medicaid. And once we've done that, we want to privatize Minnesota Care. The next 4 slides demonstrate that there was never any evidence supporting the HMO's claim that they could cut costs for Medicaid. This is, I'll go through these very quickly. This is from a study by the Kaiser Family Foundation. Now they go by KFF, from a study published in 1995. It said there's little evidence to indicate that the HMOs are increasing or decreasing healthcare services, physician visits, preventive services, hospital care. This is an excerpt from a study published in 2007 in the Journal of Health Politics, Policy, and Law, one of the oldest health policy journals in the country. Bruce Spitz, the author, says part of the appeal of placing large portions of Medicaid recipients in HMOs was the promise that costs would be reduced. That's a little inaccurate. That was the only reason initially for privatizing Medicaid. Theory was that competition between HMOs would lower costs. But he goes on to say the evidence on cost containment was particularly inconclusive. National studies on the impact of managed care on access and quality were also lacking. But none of this affected Medicaid's spectacular shift from fee-for-service to managed care. In other words, legislators in other states were as drunk on managed care Kool-Aid as our Minnesota legislators were. And here's a report on partial privatization of California's Medicaid program, indicating that it raised costs as well. We should take note of the fact that when Medicare or medical assistance are privatized, it means that the administrative costs of the doctors and the hospitals who treat Medicare and Medicaid patients also goes up, because you just got to spend more time on the phone playing Captain May-I and some other clerical duties. Here you see a report from Health Affairs, 1999, looking at the impact of managed care in rural areas. Almost all docs that responded reported increased costs from Medicaid managed care. Several noted that the increase in administrative responsibilities are especially difficult for small clinics in rural areas. Now, in the summer of '04, there were 5 or 6 of us. Donna, I keep forgetting whether you were there with us. 5 or 6 of us associated with the old Minnesota Universal Healthcare Coalition asked Representative Matt Antenza for a meeting. He was then the minority leader in the House. We asked him if he would write the then DHS Commissioner Kevin Goodnow and just ask him, does DHS at this point have any evidence indicating that privatization of Medicaid saved money? And Goodnow wrote back. He said, there no longer remains a credible comparison group of fee-for-service patients. We do not have a methodology that could accurately assess whether managed care has cost us more or less than fee-for-service. So they got away with it. They suppressed the only attempt to actually see whether managed care would work. Now here we are in 2004, when a representative asks DHS, do you have any evidence? Nope, we have none, and he didn't volunteer to offer any or dig up any. And nothing has changed since 2004. One of the most amazing things that needs to be explained, I think, to any sentient person is, how is it that Medicaid and that the Minnesota legislature, in contemplating privatizing Medicaid, or Congress in contemplating privatizing Medicare, inserting HMOs into Medicare, how is it that they never asked the question, why do we expect that HMOs who have overhead of 15% can reduce medical costs by 15% without hurting patients, and even more in order to make a buck? HMO overhead is 15% because they tell doctors how to practice medicine. They pay their managements a lot of money. They have to set up narrow networks. And you see here a statement from the Lewin Group, subsidiary of United Healthcare, simply stating that fact. MCOs, kind of the name you hear these days for PPOs and HMOs, must typically achieve roughly a 15% savings on medical costs vis-a-vis the old fee-for-service setting, simply to break even. To my knowledge, this question has never been asked by anybody in Congress who voted to privatize Medicare, or anybody in the Minnesota legislature who voted to privatize Medicaid. If we can remove the HMOs from medical assistance and Minnesota care, given that we know that their overhead cost is 15%, you give an HMO $1 worth of Minnesota taxes, they keep 15 cents to run their shop, and they pay out only 85 cents to doctors and hospitals. If we kick the HMOs out, we no longer pay that 15%. And depending upon how we measure the impact of HMOs on utilization, the total savings will be 10 to 15%. This number here, I put 0 to 5, it's a range. Research on what How HMOs impact utilization is rather crude because HMOs are black boxes. It's difficult to get in and find out what they do with their money. Some research indicates, and I just quoted some earlier in this session, that they have zero impact on utilization. Other research says it's closer to 5%, that they reduce utilizations, a lot of it necessary care, in order to cut their costs. So depending on what this number is, we can say that removing the HMOs from medical assistance and Minnesota Care will save 10 to 15% on all the enrollees who were previously in an HMO. One last comment here, the spectacular failure of Medicare Advantage, and I think you all know that's the privatized portion of Medicare, is further evidence that managed care has backfired big time. And it's not just single payer advocates saying it. You're hearing this now from establishment groups and figures. Here's a report to Congress from the Medicare Payment Advisory Commission, 2023. Private plans have never been paid less than fee-for-service Medicare. Here's a report, March 2024. Some of the co-authors are on MedPAC, saying that Medicare is overspending. They're overpaying Medicare Advantage plans by 22%. It is far worse than that, probably around 35%. To sum up sessions 1 and 2, by the early 1980s, the US was becoming much more expensive than other wealthy nations. The early 1990s, Minnesota became much more expensive than other states. Cost control tactics pioneered by HMOs, known collectively as managed care by 1985, drove up administrative costs and triggered mergers at both the national and Minnesota levels. Managed care was endorsed on the basis of no evidence for the overuse diagnosis or the managed care cost containment tools, but proponents are not fazed. They continue to claim overuse is the problem, not price.
Thank you for watching this video. See the description below for links to the primary sources used during this training. Healthcare for All Minnesota has more videos and looks forward to you joining our efforts.